and I would like to thank every one of you who have attended this conference. And now today my talk will be again, I am going to talk on gliptin, and this is a sponsored program. So this is my personal disclosure, and on behalf of Novartis, I am talking this topic. And here I am not going to talk anything new. You all know very well about gliptins, and now they have some few studies which shows that there is a pharmacokinetic difference between the gliptin. That's what I am going to talk. So managing the glycemic triad, how do the gliptins differ? So you all know the current treatment goals for glycemic control. There are so many guidelines and protocols, and all these things are going to give only safety measures in your management. And as Dr. Pichmani and the previous speakers were telling, it has to be individualized for person to person with this comorbidities and other things. The treatment is going to be individualized, and we are not going to follow all these guidelines very strictly, and we are not going to be implementing the management according to this. This is only to safeguard us. And you all know about the legacy effect. When you start the treatment early and you reach the target early, and if you maintain that for quite a few number of years, 5 to 10 years, you are going to have a benefit even after that period. If you are not going to manage that much, but still you are going to be benefited with all the micro and macrovascular benefits, and that's the legacy effect or the metabolic memory. You all know very well about this also. And benefits of good glycemic control you have seen in Wikipedias, the 32% reduction in any diabetes related endpoint, 42% of diabetes related death, and 36% of all cause mortality. And sulfonylurea insulin based therapy, there is 12% for any diabetes related endpoint, and 10% for diabetes related death, and 6% for all cause mortality when you see with the most potent secretagogue, that is the sulfonylureas and the insulin based therapies when you compare with metformin. And but how long is this thing you are going to manage with OHAs? And in the Wikipedias again you have seen whether it is a conventional treatment or with glibenclamide or with insulin or anything, it is only for a few years, that is just 6 to 8 years. Nearly 60 to 70% of the type 2 diabetics will require insulin or the other management in the management of diabetes. So in the management of diabetes, again, if you are going to have a high HbA1c or a low HbA1c, again it is going to be it is going to increase the mortality. So it is very tough to maintain a HbA1c of less than 7. When you reach after 7.5, when you are trying to reach 7, it is going to be very difficult with hypoglycemias and the weight gain and other problems. And again, they have found that the lowest risk is with the HbA1c of less than 7.5, because after when you treat with your conventional drugs like sulfonylurea and other things and all, you are going to have experienced hypoglycemia and weight gain, which is going to be a big problem when you reach the target of less than 7. So, and this Accord Advance and VADT showed that severe hypoglycemias in the Accord trial, we have seen that has caused increased mortality, and in all these trials, an episode of severe hypoglycemia associated with an increased risk of subsequent mortality. Hypoglycemia and cardiovascular events in advance, again that showed the which predisposes to hypoglycemia, predisposes to any cardiovascular events are seen in advanced trial. And blood glucose profile over the 24 hours in type 2 diabetes, you all know it varies a lot with breakfast, lunch, dinner and other things. So there is a lot of glycemic variability will be there when you are managing the diabetes, and whether this glycemic instability or the variability is going to increase your mortality or not, still it is a question. Many say that I think there is a important thing in the glycemic variability. Yes, it causes increased mortality. Some say we don't have any evidence. And you can see the 24-hour CGMS here in 4 different patients, and all of them had the HbA1c of 6.7, but still you can see the glycemic variability. It is not the same in all the 4, it is different. And your fasting hypoglycemia, you know, because of the hepatic glucose output and because of the lack of basal insulin, your hepatic output is more and your fasting hypoglycemia is there. That's how your fasting hypoglycemia has increased in type 2 diabetes. And postprandial hyperglycemia, it has been influenced by blood glucose level before the meal. If your fasting is going to be high, again your postprandial is going to be high, and the glucose load what you take during the meal, that is also one more important factor for the postprandial hyperglycemia. And the insulin secretion and the insulin sensitivity, again if this thing depends upon that in the peripheral tissue also, your postprandial glucose is going to increase. And again here you can see 5 different patients, 24 hours CGMS. Again that's not the same with the HbA1c and the fasting postprandial is also totally different in all the 5 patients, possibly because of the daily plasma glucose variability and postprandial glucose excursions are the reasons for this difference in the glucose profile of these 5 patients. And the glycemic triad you all know very well, and it is familiar, the HbA1c, fasting plasma glucose and the postprandial control. It's all these things is very important in the reaching the target. Now more than that, we have the other factors like the glucose fluctuation which increases the MACE, the activation of oxidative stress, and activation of oxidative stress, which all increases the risk of complication, that the thick bar you can see. And this model is suggested for illustrating the pathophysiological impacts of excessive glycation of proteins and activation of oxidative stress on the risk of diabetic complications. That is the diagonal solid arrow you can see here. And effect of vildagliptin versus sitagliptin on the plasma levels of GLP you can see here. This orange color is the vildagliptin, and sitagliptin here you can see 100 milligram once daily, and vildagliptin 50 milligram BID. So the difference can be seen as early as 1.5 to 3 hours post dose, so that the different regimen should not be the main cause of the difference. And this is a study, Optima study, which compared the vildagliptin with sitagliptin. The results you can see, the Optima study, vildagliptin versus sitagliptin, main results. The mean CGM profiles at baseline with metformin alone, that is a black line, and after 8 weeks of addition of DDP4, that is the red trial, you can see with the vildagliptin the difference in the hyperglycemia, and with sitagliptin you can see a different pattern, and here it shows better. We will see how is that. That is significant better with vildagliptin on all parameters of glycemic exposure and circadian glycemic control, mean of 24 hours time spent in ideal range, area under curve in hyperglycemia, and control of basal and total hyperglycemia. That's how they have seen in this trial. And you can see here the time in minutes spent in ideal range, that is between 70 to 140 milligram, which is being compared with vildagliptin and sitagliptin. Here you can see the baseline, and after the 8 weeks period you can see the differences seen with vildagliptin, whereas with sitagliptin we are not seeing the difference. So in the conclusion of the Optima study, the addition of DPP inhibitor significantly reduced glycemic variability with no difference between the two drugs, but however vildagliptin induced better circadian glycemic control than sitagliptin, and with a significant decrease on overall hyperglycemia, mainly driven by the reduction on basal hyperglycemia. And the effect of DPP inhibitors on biomarkers you can see between the sitagliptin and vildagliptin. Vildagliptin scores better in reducing the inflammatory markers or the biomarkers than the sitagliptin. That's what's seen in this Optima study. And again here also you can see the Barberi et al. He has taken this data was from 12-week prospective randomized open label parallel group trial with a blinded endpoint study on 90 patients with type 2 diabetes, assessing the role of dipeptidyl DP4 inhibition in lowering oxidative stress and inflammation by reducing the daily acute glucose fluctuations were included in this patient analysis. You can see the baseline, and after 3 months in the vildagliptin group you can see the reduction. So the ideal approach, treatment of both fasting and postprandial should be initiated simultaneously at all levels of HbA1c above agreed levels. That is the ideal approach. And ideal choice for new type 2 diabetes is combination of metformin and a DPP4 inhibitor, as the previous speakers from morning, Dr. Anand Moses and others have been telling. And the target the two key pathological features of type 2 diabetes is loss of the first phase insulin secretion, that has to be restored to some extent, and the insulin resistance has to be taken care, which is a very important factor in the type 2 diabetes. And the role of GLP, you all know very well, GLP in the glucose homeostasis, and you know it's this here, you know very well, you would have heard so many times. And how do these gliptins differ? Now is the important point and the important message with this talk. The real difference is in the pharmacokinetic and the action, that is a mechanistic data advantage, that is the substrate and binding kinetics of the different gliptins has some advantage, which is, I can't say it's very significant because it is totally a gliptin effect with all the gliptins, but here there is a little difference, that's what I am going to enlighten here. And the BAD dosage advantage, because all the most of the gliptins if you take, it is once daily preparations, and now they have come with BD preparations, but here BD dose advantage is very good in the 24 hours control when taken with vildagliptin. I will tell you how, and there is a significant reduction in the fasting plasma glucose when compared with sitagliptin. I will show the data here, and this is the mechanism of action, how it is going to differ. You can see here the sitagliptin and allogliptin, they are competitive enzyme inhibitors, because that means they have a faster association with the receptor and a faster dissociation of the receptor, that is hit and run like action like glimepiride. Whereas if you take the vildagliptin and saxagliptin, they are substrate enzyme blockers where the association will be faster but the dissociation will be very slow, that is the receptor affinity will be more, so the dissociation or the binding capacity of the vildagliptin after association is very stronger. So that is the difference what we see with these molecules, and you can see that's been compared here. Off-rate kinetic comparison, here you can see the half-life of enzyme inhibition complex with the vildagliptin is nearly 55 minutes, and here with sitagliptin it was very negligible, that is the association and dissociation from the receptor binding. So this is an important message from this talk, and you can see this expected from a covalently bound inhibitor, that is your vildagliptin, and this non-covalent competitive inhibition is by the sitagliptin, that is the difference. So vildagliptin added a stable dose of metformin more than 1500 milligram per day elicits a dose related decrease in both HbA1c and fasting plasma glucose. You all know very well when gliptin as a monotherapy, when it is compared with the combination with metformin, the synergism increases and you have more than double the benefit when compared with the monotherapy of gliptins. And here they can see vildagliptin 50 milligram approximately, the reduction was 1.1% when it has been given as a monotherapy. When it has been combined in drug naive type 2 diabetes, you can see vildagliptin 50 with metgram 1 gram BD, approximately 1.8% drop is there. So then that is the synergistic benefit of this combination. So overnight effect of evening dose of vildagliptin with prolonged DPP4 inhibition, and that is a stronger affinity, because of stronger affinity, there is a sustained overnight effect with twice daily dosing. That's the advantage what we have with the vildagliptin, may potentially offer clinically important outcome when added to metformin. So vildagliptin and metformin increases fasting GLP-1 levels through a complementary mode of action. That's what has been said in this graphical representation. And efficacy of vildagliptin and sitagliptin in lowering the fasting plasma glucose was been studied, and in this again you can see significant reduction in the fasting plasma glucose with vildagliptin versus sitagliptin. Here you can see the difference. Higher reductions in vildagliptin could be mainly due to the natural substrate like binding of DPP4 inhibition versus competitive binding of the sitagliptin. The sitagliptin has a very faster and association and dissociation. Because of that the reduction might not be more, but with vildagliptin the association and the dissociation is very very slow. Because of the stronger binding, overnight binding, you might have a very good fasting reduction. In conclusion, both sita and vilda lowered fasting plasma after 14 days treatment. However, vildagliptin produced significantly a greater reduction in this fasting plasma glucose from versus baseline compared with the sitagliptin. And now we see the efficacy of DPP4 as add-on to type 2 diabetic patients uncontrolled on dual combination of oral anti-diabetic drugs. Here you can see it has been compared with HbA1c reduction. You can see sitagliptin, saxagliptin and vildagliptin. fasting plasma glucose and postprandial reduction. Higher reduction is fasting plasma glucose with the vildagliptin could be due to the, I told because of the stronger receptor affinity and covalent binding of vildagliptin, that is also one more reason for it. And whereas a non-covalent binding of sitagliptin with DDP4 and the twice daily dosing of vildagliptin versus once daily of saxagliptin and sitagliptin. So the result is greater reduction in fasting plasma glucose. Here you can see the fasting plasma glucose is nearly 2.4. So vildagliptin added group showed the greatest reduction, which was statistically significant, while sitagliptin added group showed the lowest reduction, and that is also statistically significant p-value in terms of fasting plasma glucose. In summary, higher reductions in fasting plasma glucose with the vildagliptin could be due to the structural differences in the receptor affinity and covalent binding of vildagliptin with DDP4 and the twice daily dosing. These are the reasons for better fasting plasma glucose. Although target HbA1c levels can be reached by lifestyle modification together with drug therapy, optimal glycemic control may be best achieved by selection of drugs that target both fasting and postprandial in selected cases where you want good reduction in both fasting and plasma. Thank you.
Okay, in the absence of any further questions, let me request Dr. Manavalahan to present this